threat in critical care. Probably you might have seen that amoebic encephalitis cases have risen in states like Kerala. Earlier in previous year, the total reported official cases were 7 to 8. But recently, the total spurt in amoebic encephalitis has gone on to 71 almost. So we found that this could be a possible threat and there could be several challenges associated with treating amoebic encephalitis. Today, we are having very eminent clinicians and very brilliant academic person, Dr. Jitesh Gangadharan, who happens to be the HOD, head of the Department of EMS Memorial Cooperative Hospital and Research Center Limited, Perinthalmanna, Kerala. We are very fortunate to have you, sir, for this meeting. And through this particular meeting, we are trying to address this very critical condition called amoebic encephalitis in critical care. In this particular meeting, we would like to delve in depth that what all are the modalities of the treatment available. And should you have any queries, please post that particular queries into the chat bot so that we can collect these particular queries and Dr. Jitesh would be happy to answer these things. So without much ado, I just would like to hand over this particular session to Dr. Jitesh to take us through what is the amoebic encephalitis and what are the things that we are supposed to do. Over to you, sir.
Yeah, thank you. Thank you for the introduction. So, am I audible? Am I audible to everybody?
Yes, sir.
Yes, sir.
Yeah. So, about myself, I'm Dr. Jitesh. I'm currently working as a consultant and head of the department in EMS Hospital, Perinthalmanna. So, today's topic is like amoebic meningoencephalitis. So, I would like to thank Microlabs for organizing such a nice program. So, let's get started. So recently, Kerala has been in spotlight because of due to rise in the cases of meningoencephalitis. Like, see, these are some clippings. Like Kerala brain-eating amoeba cases are surging. So today we will be going in depth about how what is happening. So, like, let's have some brief introduction about amoebas. Amoebas are environmental protozoan parasites with worldwide distribution. So they survive independently in nature. No host or vector is needed, and there is no specific parasitism, no adapted parasitism with humans. But occasionally, humans and animals may get infected. So out of the free-living amoebas, only so far six pathogens have been identified. They are like Naegleria, Acanthamoeba, Balamuthia, Serpinia, Wormamoeba, and Paracambia franci. So out of this, Naegleria fowleri is the most pathogenic, and it is the most pathogenic organism. So in central nervous system, they basically cause two types of syndromes. One is primary amoebic meningoencephalitis, and second one is granulomatous amoebic encephalitis. So I'll be going into detail of that a bit later. So first, about the first published case report about amoebic meningoencephalitis happened in the year of 1965. So there were 4 cases were reported. Three were kids of age of 8 to 9 years old, and the other one was a 28-year-old. The case report came from Australia, and what they found out was when they did the autopsy of the patients, they found out that amoeba was been visualized inside the brain parenchyma. So they have actually suggested and so far at that point of time there was no case reports or defined cases of amoebic meningoencephalitis. So this was the beginning of this thing. So this started in the year of 1965. So epidemiological distribution. This is from a epidemiological details is from from a case report from a study that has been published in the year of 2022. The data has been taken in the year of 2018. They have considered all the published case reports along with the CDC data. Based on that, they found out that the maximum incidence of amoebic encephalitis is in US with a 156 cases. Second was in Pakistan and third was in Mexico. At that point of time, there was around 26 cases so far reported from the year of 1965 to 2018. So in that study itself, they found out that the different source of infection, like what happened was like the people who acquired infection came into contact with like swimming was there, bathing in the freshwater pond was there, water sports were there, nasal irrigation, splashing of water, all was present. And the water source was like either it may be a lake, pond, or reservoir water, swimming pool water, or tap water. All has been suggested as the pathogen, has been responsible for the etiology for the contact source. So next, coming to the demographic details. Out of that total patients, males were most commonly affected because most of the males are usually involved in the water sports related activities. That may be the reason why there is a male predispositions. And outcome out of this total 381 cases, the mortality was nearly 96%. And the median range of incubation was like 5 days from the contact with the water bodies. So now let's come to the Kerala data. So in Kerala, there has been recently a rise in amoebic meningoencephalitis. So if you compare the year 2016, 19, 20, 22, the number of cases reports were like 1 or 2 cases, and the mortality was almost 100% till the year of 2023. In the year of 2024, till July, around 8 cases were reported, and out of these, 4 patients survived. So things started to change a bit in Kerala. And once you come to the next slide, if you see in this slide, if you see the out of by the end of 2024, out of total 39 cases, number of deaths was only 9, and which is like only 28%, which is very different from the other world data, which in which the mortality was somewhere around 97%. And this is the data in the year of 2025. See, if you see, there is a gradual increase in the number of cases, and it is been maximum in till in I have data till August. There are around 18 cases, and so far 40 cases has been reported in the till August. And out of that, the number of deaths been 10 cases. So again, the mortality is only 25%. So what all are the reasons that are responsible for rise in meningoencephalitis? So one thing is like there is a global warming is happening, and this amoeba being a organism which prefer bit warmer climate. So that is one reason responsible for the rise in cases of meningoencephalitis. Global warming has been suggested in the main reason responsible for the rise in meningoencephalitis. And the other reason is like if you even compare the data from the Kerala, like there's not much increase in the total incidence of meningoencephalitis. What is happening right now is more and more number of we are going for more and more etiological diagnosis of meningoencephalitis. See, Kerala has been recently affected a lot of like Nipah and all. So what happened? The diagnostic facilities and clinical suspicion has become more developed, and we are going for an advanced test. So because of that, we are going for a better etiology-based diagnosis rather than labeling it as meningoencephalitis. So because of the Nipah, there is a heightened vigilance is happening. So because of that only, we are pushing for the most exact diagnosis. And difference in there is a big difference in the Kerala guideline from the CDC guideline. I will come to that later. So now let's go to the topic first, that is primary amoebic meningoencephalitis. So it is an acute hemorrhagic meningoencephalitis that is caused by Naegleria fowleri. It causes fulminant meningoencephalitis, almost similar like bacterial meningoencephalitis. And about Naegleria fowleri, it is a thermophilic amoeboflagellate which lives above 30 degrees Celsius and tolerate up to 45 degrees Celsius. So this is the important thing. Since this global warming has been suggested as an important role in leading to the rise in amoebic meningoencephalitis. So in the life cycle, the infective stage are trophozoite or trophozoite, and there is a transient flagellate stage and a transient cyst-like stage. So the cyst which is present in the fresh water may get converted to trophozoite, and which is the pathogenic form. The humans will come across the organism while doing the swimming, and other water sports related activities. Once it happens, the organism will come and come in contact with the nasal mucosa. It will penetrate the nasal mucosa, and via olfactory nerve and olfactory bulb, it will enter into the brain parenchyma and causes meningoencephalitis. So, the primary amoebic meningoencephalitis, actually it's a fulminant disease, more like a type 1 hypersensitivity reaction to the amoebic meningoencephalitis, because it causes a fulminant disease, and the mortality in the literatures are very high, like up to 97%. So the characteristic features of primary amoebic meningoencephalitis, like it commonly affect healthy and healthy children and young adults, more common in the warm months, and recent freshwater exposure has been suggested. So one important symptom they may suggest other than the typical signs of meningitis are altered smell is suggested, and it mimics acute meningoencephalitis. It has a fulminant course, like rapid onset between 1 to 2 days. Then it is a very like it's basically a cytokine storm is happening, and it will lead to destruction of the brain parenchyma, very bad cerebral edema happens, and thereby leading to the death. So there has been suggested a different stages has been suggested. First is the stage 1, that is nasal stage, in which the organism first will come and contact with the nasal mucosa. So sometimes what happens is this organism, once it reaches the nasal cavity, it will come in contact with the olfactory nerves, and then it will start via the olfactory nerve. It will migrate into the brain parenchyma, and it will lead to the meningoencephalitis. So these all are the three stages, like nasal, olfactory, and meningoencephalitic stage. See, these stages, because we won't get a patient who is in nasal stage or olfactory stage, because most of the cases comes in meningoencephalitis stage only. So this may be later we can use for some research purpose or some prevention purpose. No, so far there is not much we can do with this knowledge. So, like, what all are the clinical features? The patient will have high grade fever, severe headache, photophobia, nausea, vomiting, behavioral change, seizures, altered mental sensorium. Then meningeal signs will be positive. Cranial nerve palsy may be there, and eventually leading to uncal herniation, and may lead to brain death and lead to death. So, like, once, how will you investigate the patient? So, first, most common investigation that we will do in this scenario is like, in blood there will be leukocytosis with neutrophilia, and next is the CSF. In the CSF, initially it may be yellow white, or later stages it may be hemorrhagic. As earlier I told, it mimics bacterial meningoencephalitis. So the main cells will be neutrophil predominant. 300 to 25,000 cells can be seen. RBCs are also being seen, and glucose will be low, and protein will be high, and very high opening pressures are seen, and gram stain and cultures are usually negative. So this is again from the same data. In that data, we can see the opening pressures were high, like around 380, average of 36 to 530 with a median value of 380. Red blood cell were like 0 to 750 with an average of 2, median of 212. Neutrophil predominant, again 90% were neutrophils. So now, how to collect the sample? This is most important. So for the most specific diagnostic test is a wet mount preparation. So in once you see a trophocyte inside the CSF, it is like amoebic encephalitis is possible. The next thing what will we do is like we have to find out what type of organism it is. So for visualizing a trophocyte, the preparation of the slide should the wet mount should be adequately prepared. So first and foremost thing, before doing LP, you should inform your microbiologist that yeah, we are planning to do LP in so and so patient, and we are suspecting amoebic meningoencephalitis. We need a wet mount. So once the CSF is done, keep the CSF in room temperature at 25 degrees Celsius. Do not refrigerate or freeze. Once you refrigerate or freeze, this organism is not visualized. And once the sample is reached there, you can gently agitate before centrifuging it, because many times the organism may be adhering to the container, and you can centrifuge it at 5000 Kelvin for around 5 minutes, so that the amoeba concentrate in the bottom, and then you can examine it. And the other way is like you can use right stain, which is used to visualize the this thing. So phase contrast microscope will help in earlier detection. This is the guideline, that is this how to collect this sample has been suggested by the John Hopkins Children's Hospital. So, so basically, we will suspect this thing once we are suspecting a patient with with a bacterial meningitis like picture with negative bacterial and viral results. History of water exposure may be present, but it is not always present. Gold standard is like motile trophozoite that is obtained from the centrifuge CSF. The trophozoite is usually about a size of 10 to 25 and it has a single nucleus and a single nucleolus. Then once the specific trophozoite is visualized, we will diagnose amoebic meningoencephalitis and we will initiate the treatment. The other way is like we can also send a PCR for CSF. This PCR will help in identifying the specific type. In this case, in primary amoebic meningoencephalitis, always Naegleria fowleri and culture, usually there won't be any growth, and role of CT and MRI. CT and MRI don't have a specific role because the findings are non-specific. There will be brain edema, basilar and meningeal enhancement, hydrocephalus will be there, brain infarction will be there, and these are the common things. Almost all part of the CNS can be affected, like brain as well as spinal, up to spinal cord can be also involved in this case. So how will you treat it? So that the early suspicion plus immediate treatment is very important because once the symptoms on it, the patients usually expire very fast. So the mortality percentage is also very high because many times we miss the diagnosis, and once you diagnose it, the time has passed, and the cytokine storm and cerebral edema and all are very bad, and eventually we will lose the patient. So basically what we have to do is like we have to initiate the mainline treatment. Along with it, we have to start the supportive treatment. So the supportive treatments, I'll come to that later. So basically the conventional amphotericin B is the drug of choice. Here it can be given as mainly it is given as IV. Along with it, intrathecal admission may be also can be also given. Compared to the conventional amphotericin, usually we prefer liposomal amphotericin, right? But in this case, this is the one case where conventional amphotericin B is the main drug of choice. So usually what we do in a case of primary amoebic meningoencephalitis, usually we give a cocktail of drugs. Like we usually give out of this, we give these all these drugs together. Like usually we will give amphotericin B for 14 days. Then along with it, we will give azithromycin, fluconazole, rifampicin, miltefosine, and dexamethasone. So the dexamethasone is given at a dose of 0.6 mg per kg. We give it as a divided dose for 4 days, basically to control the brain edema and the inflammation that is happening in the brain. And miltefosine usually we give at a dose of 50 mg BD for a patient with a weight of less than 45 kg, and in a patient with a weight of more than 45 we give 50 mg TID. Then like amphotericin B will give at a dose of like 1.5 mg per kg per day for 3 days, and rest we continue at 1 mg per kg daily for 11 days. So like this is the treatment literature. If you see the literature, almost every cases they have used amphotericin B, azithromycin, fluconazole, miltefosine, and rifampicin, and the duration of treatment is almost around 28 to 30 days. This is the same thing that is what we is following here also. So these all are the, again one more thing, one more time the same thing, that is amphotericin B, IV plus intrathecal, rifampicin, fluconazole, miltefosine, azithromycin, and the other drugs that has been suggested that can have some role is like voriconazole, phosphoconazole, it have been suggested. Then like these all are the other drugs that has been suggested. So I had already told that we are already giving dexamethasone for controlling the brain edema, but there is specific indication for pulse methylprednisolone. Like actually, if the condition of the patient is deteriorating very fast, like if the patient's GCS is falling below 8, rapid fall of GCS, rise in intracranial pressure, and there is intractable seizures that are not responding to anti-epileptic, necrotizing encephalitis with cytokine storm. These all are the conditions where we will consider prednisolone pulse. It is basically what we are trying to do. We are trying to suppress the cytokine storm, and usually the dose is like 30 mg per kg per day for 3 days, and it should be initiated after expert opinion. So Basically, in case of primary amoebic meningoencephalitis, the one thing I will specify is like a short incubation period and rapid progression of disease. So always suspect primary amoebic meningoencephalitis, and preparation of wet mount is the most important thing. And the treatment is always a cocktail of drugs, and steroid holds a very important role in this thing to suppress the inflammatory path. And if the disease is progressing rapidly, always consider to give pulse methylprednisolone. Next, let's go to the granulomatous amoebic meningoencephalitis. It's a rare subacute chronic infection caused by Acanthamoeba balamuthia or Saffinia species. So basically, it affects all age groups. Extremities of age are most susceptible and commonly seen in immunocompromised population. And seasonality is like there is no specific seasonal variation, like it can happen at any particular month. Usually sometimes it may be associated with other skin manifestation, keratoconjunctivitis, or skin manifestation or skin lesions may be there. There will be a chronic or subacute course. But actually in Kerala right now, we are even getting acute presentation because of due to the increased suspicion. Once the population, the people, once they are have contact with the water and they develop meningitis like presentation, they are coming up earlier, and we are doing a wet mount. We are even getting the granulomatous. Like, see, we are getting this acanthamoeba and all this even in the acute phase before. Like, see, this granulomatous phase usually happens after a chronic phase because of the type 4 hypersensitivity. But even in Kerala, this because of the early improvement in diagnostics, we are getting the diagnosis earlier stages. Like, even before the any particular brain parenchymal lesions happen, we are able to diagnose it. So these all are the some skin lesions that are seen in patients with this granulomatous amoebic encephalitis. See, these are showing classic plaque lesion on the central face, then some lesions over the nose, then annular plaque in the near the knee has been also shown here. So usually, if it is a chronic course, the usual presentation will be like subacute to chronic course, gradual progression of symptoms, headache will be there, and low-grade fever will be there, visual disturbances will be there, neurological features like focal neurological findings may be there. Sometimes in HIV patients, it may even mimic toxoplasma like encephalitis. So, so I'm just this slide is again the continuation. So in the advanced disease, what happens is like once there is a space occupying lesion, there will be gradual increase in the pressure. Seizures can happen, and once the edema and all set in, there will be loss of consciousness. It may progress to coma and eventually death. So, in case of how will you diagnose granulomatous amoebic encephalitis? The tissue diagnosis is the gold standard. Once you do the hematoxylin and eosin staining, the trophocyte can be seen, which is of a size of 50 to 30 micron, and located in the perivascular space with a central with a large nucleus with a centrally located nucleolus, and other sites like the same organ trophocyte can be seen in the skin as well as the pulmonary lesions also. So these all are the two slides which show here hematoxylin and eosin staining of the trophocyte, which has been shown here. So, tissue culture sample culture can be done. Then molecular method like PCR can be again done because this help in rapid diagnostic and help in identifying the pathogenic species. Then neuroimaging like CT or MRI will show ring enhancing lesion with space occupying ring enhancing lesion. The common sites are temporal and parietal lobe. The common differential diagnosis is like tuberculosis, nocardia, bacterial brain abscess, aspergillosis, cryptococcosis, histoplasmosis, and CNS lymphoma. So actually one thing specifically the Kerala guideline right now suggested is like sometimes we will start empirically treatment for tuberculosis based on the clinical presentation. So at this point they have suggested before initiating the ATT drugs, it is always better to start get a wet mount preparation. Sometimes this may be a case of chronic granulomatous amoebic meningoencephalitis. So wet mount preparation is very important again. Then like how will you treat it? A combination of drugs like sulfadiazine plus pyrimethamine plus fluconazole is used, and surgical resection of CNS lesion may be needed plus or minus rifampicin. And the other cocktail that has been tried is like intravenous or oral cotrimoxazole and flucytosine has been also suggested. In case of sapenia diploidia, the treatment that we usually give is like azithromycin plus pentamidine plus itraconazole plus flucytosine and plus or minus surgical resection of CNS lesion. In case of Balamuthia, again flucytosine, pentamidine, fluconazole and sulfadiazine and azithromycin. These all are the drugs that we give in case of this. Usually, basically, the drug we give is like a cocktail. So, about my personal experience, actually, we got a 18-year-old child. The child came with a history of fever, fever and headache, like 2 days. And so the family has consulted a local doctor over there. They have started medications, and the patient's clinical condition gradually worsened. Then he started to develop uh, generalized tonic-clonic seizure in the home, and for which he was brought to our hospital. In our ED, the patient had multiple episode of generalized tonic-clonic seizure. He got intubated and was shifted to the neuro ICU. And over there, what happened was like the patient's GTCS didn't subside. Patient continued to continued to have seizure. We started to give like all the anti-epileptics, and eventually the seizure got settled with ketamine. And lumbar puncture was MRI was done. MRI again was non-specific, nothing specific was there. And once we did a lumbar puncture, it was the picture was almost similar like bacterial meningoencephalitis, and we sent a bacterial panel, and PCR panel was sent, and the patient was started on broad spectrum and antibacterial. And but the patient condition gradually started to deteriorate. And again we seizure, again breakthrough seizure used to happen. So again we revise the history. So once they again we revise the history, the patient bystanders was telling like the patient had been taken bath in a recent pond. So we got a suspicion of this thing, and by the time the bystanders wanted reference to Calicut Medical College, and patient was referred there. And once the patient reached there, they did a repeat LP, and again repeat LP was showing the trophocyte was visualized. Before initiating the patient, we the patients come down. So the what I want to suggest is like the window is very low. Even within 2 days, we will lose the patient. So always suspect this kind of disease very faster. And and in the over there, once they visualize the trophozoite, again it was a case of Naegleria fowlberry, I think. Then the baby, that's it. Now something new. This is actually a case that I got from Dr. Arvindan sir. Actually, I need to thank him. These are the slides of him. So this is like a case that they encountered in Trivandrum. A 29-year-old male who came with history of fever with chills with 1 day duration. Patient had a headache and vomiting for 7 to 8 episodes, followed with altered sensorium from 8 p.m. On 24th, and there was no history of in bathing in ponds or anything was present. On presentation in ED, the patient was drowsy, blood pressure of 110/70, saturation was 98% in room air, neck stiffness was present, and RBS were normal. So the patient had a history of RTA in 2018, which he had undergone traumatic brain injury and EDH. With along with there was a fracture of left orbital frontal bone, and there was a travel history. The patient was working in Tamil Nadu. The most important thing was he had a history of substance abuse, and history of vaping was present. So what happened? Like the as the patient had progressively developed fall in GCS, once the ONSD was done, it was increased. The patient was intubated and mechanically ventilated. The CSF profile was like the cell count were 413. It was neutrophil predominant with high protein and low sugar. Uh, uh, it was like a typical bacterial meningoencephalitis. The patient was started on ceftriaxone, vancomycin, and dexamethasone. But considering the possibility of the patient had vaping, a CSF wet mount preparation was performed under the direct microscopy, and the trophozoite was visualized. So, but at the same time, the multiplex PCR was also being sent, and the multiplex PCR detected Streptococcus pneumoniae. So the antibiotic ceftriaxone was continued, and amoebic CSF PCR came negative for Acanthamoeba, Naegleria, and Balamuthia. Then the MRI brain was revealed meningoencephalitis with a patchy involvement of right occipital, bilateral frontoparietal cortex and splenium. So again the trophozoite was visualized while the PCR panel was negative, and multiplex PCR was showing a specific bacterial pathogen. So what they did was they continued the antibiotic along with anti-amoebic measures, and so this is one thing. They continued this treatment. So I'll come to that case again. So this is something very important. This amoeba is one thing as something peculiar. The amoeba usually phagocyte this bacteria. That is how it survives. And this so because of this thing, the amoeba can act as a Trojan horse because it can carry the other bacteria like Acanthamoeba, worm amoeba, and Paravalcampia are capable of carrying other pathogens inside them like Legionella, Pseudomonas, Aeromonas, and fungi and algae can be present inside this amoeba. So once they infest us, they can even it can lead to multiple co-infections. So like in the Trojan horse, like in the case of Trojan horse, the inside the Trojan horse, we were expecting Ajax, but we were surprised to find Achilles. It's the same thing happened here. Like the like Acanthamoeba can there are case reports which says that Acanthamoeba can have co-interaction with Streptococcus pneumonia and also Streptococcus pyogenes because they act as a vector by providing shelter and facilitating the growth for these organisms. The same thing has happened here. So the treatment was continued. The patient continued to receive both antibacterial as well as anti-amoebic treatment. Then after 2 weeks again, the PCR was repeated. The PCR again showed the positivity for amoeba. And after 2 weeks, a repeat CSF study was done. Repeat CSF study showed a decrease in the number of cells. The sugar count was sugar was normalized, protein was normalized, but again the trophozoite was persisting. And during the course, the amphotericin B was stopped by them because the patient started to develop AKI. And they continued the treatment. Gradually, the patient improved. The patient was discharged on day 45 with cotrimoxazole and doxycycline, and a repeat CSF study was done at day 60. So no trophozoite was seen again, and MRI brain was normal. So why I bought this peculiar case was most of the guidelines say that usually we need to suspect amoebic meningoencephalitis when there is no specific etiology present. If we get a specific etiology, they say that there is no need to go for further investigation. But this case itself shows that this is not the true reality because they can act as a Trojan horse and they can bring the other organisms together. So it is always better to have a wet mount preparation in almost all cases. And this also suggests the role of molecular diagnostic because once we visualize the parasite, we were again able to, after 2 weeks, again the PCR test came positive. So always suspect co-infection. So the difference in the Kerala beyond CDC guidelines. So the guideline that has been issued by the Kerala government, in that case, usually as per the CDC, usually they suggest once there is a specific exposure may be there. But in our real life scenario, what we found out that some cases the history of exposure may not be identifiable, and almost all cases free living amoeba act as a Trojan horse. So co-infection with FLA must be always ruled out. So it is always better to do a CSF wet mount for motile trophozoite, irrespective irrespective of the irrespective respectively. So whether there is an exposure, irrespective of the exposure history. Then let's go to the critical care perspective. So once we get a case patient suspected with maybe a history of any encephalitis, We should always take a proper history like exposure to swimming, diving in lakes, rivers or ponds or any poorly chlorinated pools. Then sometimes this nasal irrigation with native pot may be the ritual habits may be responsible, like vaping may be also responsible for all these cases occurrence. So we should take all this history like dust, soil exposure, contact lenses, about recent travel like to hot places and all, and whether the patient is any immunosuppressed, whether the patient is receiving is having diabetes or any chemotherapy or any transplant recipient, that history we should specifically try to elicit, and always suspect it. That there has a fulminant course like rapid course in 1 to 9 days usually happen in case of primary amoebic meningoencephalitis. Then bacterial meningitis picture with culture and PCR, bacterial culture negative and bacterial PCR negative, maybe that may be one evidence that it is a case of primary amoebic meningoencephalitis. The granulomatous amoebic meningoencephalitis usually keep as a differential for every ring enhancing lesion that you encounter in brain. The MRI brain may be normal in the initial presentation, and once you visualize the trophozoite, always go for a PCR so that we can find out what species it may be. So if it is not a if it is not Naegleria fowleri, we can avoid the drugs like uh, amphotericin. Like we can avoid these drugs, and then other thing is like sample processing. Always keep the CSF, do the wet mount immediately. Always inform microbiologist earlier itself. Then flagellation test. If you added flagellation test for Naegleria, like if you added distilled water with CSF and if you visualize the flagellate forms of Naegleria can be better visualized. Then other specimens like corneal scraping and skin biopsy can be along with done with it. And role of PCR I had already discussed. Then basically like think out of the box, like always think out of the, see if the patient is condition is clinically deteriorating and is not if the presentation is like a bacterial meningoencephalitis patient is deteriorating rapidly, that to do a wet mount it will take only some time, and repeat the sample, so sometimes we may be able to diagnose it earlier, and again educate the lab staff. So these all are my references, and that's it. Thank you. Any questions?
Thank you, Dr. Jitesh. It was a very in-depth discussion. I think that, for the audience, we have got somewhere 150 live audiences, but steady viewership is almost 50 to 55 audiences have been listening to what you have been actually telling us regarding the treatment modalities and all the other parameters. I have got a question from audience, and they are asking that, apart from Kerala government, is there any government protocol which is already in place for this disease?
No, sir. At this point, there is no, the Kerala government, because there is a recent trend. This guideline has been came 1 year earlier only. This is based on the recent data only. There is no other guideline at this
Thank you.
point of time. Yeah.
Thank you. Thank you, Dr. Jitesh. The second question that has been asked by the audience is, there is a part in only in the state of Kerala, but I have also got a couple of, incidences reported from rural West Bengal, wherein, doctors are also treating these amoebic encephalitis, day in and day out. Now, the audience is asking why there is a part in Kerala, not in other states of India.
Sir, actually, what happened at this point is that because of this, due to the rising incident of this Nipah encephalitis and all, the diagram we are going more for like we are somehow trying to desperately found what is the etiology responsible for it, and this wet mount and all been done, like see even the CDC guideline recommend to do it only if you don't find any particular cause. But in our case in the Kerala, what we are doing it is like we are making it compulsory for every person, every CSF we are getting a wet mount done. So because of that only the cases has been detected earlier. So that is what is happening at this point. And but there is not much increase in the total percentage of meningoencephalitis in the Kerala. So one thing maybe the earlier diagnosis, and we are going like a lot of unanswered meningoencephalitis turned to be because of amoebic encephalitis. That is what is maybe the reason.
Thank you, Dr. Jetes. I think that your session has given us an in-depth knowledge, and this recent part in the cases actually has posed a kind of big threat to the critical care specialists all over Kerala, not only in Kerala but other states of India as well. But this particular session will help us to look into these particular things very, very minutely, and I think that this session will help us to treat it on time, because as you have mentioned that the window of treatment is very, very short, and you have to take a lot of precautions. You have to do clinical judgment, and your clinical acumen is at end is going to tell that what would be the plausible outcome. Thank you very much, sir, and I really appreciate for taking time out from your very, very busy schedule, and I look forward to having you in our next program. And for the audience, let me tell you that we are coming very shortly with another INQUEST program on H3N2. And this H3N2 has also seen a lot of spot in cases, particularly in states like Kerala. So with that, we would like to take a kind of a call today. We are going to say good night. And once again, a heartfelt gratitude and thank you to Dr. Jetes for attending this particular session as a faculty and taking us through a deep insight treating encephalitis. Thank you very much, sir. We are really indebted to you for sharing your knowledge and insights. Thank you.
Okay. Thank you. Thank you. Thank you everyone for joining.
Thank you, sir.
So there was one question, like, can we clinically differentiate?
Yeah.
Yes.
Can we clinically differentiate between granulomatous amoebic meningoencephalitis and primary? No, see, the symptoms are like, see, one thing is like with the presentation in acute phase, both will look alike. The granulomatous will have a gradual progressive course, but if we go for an earlier diagnosis, like earlier stages, it will look both will look alike only. So that is not possible to detect distinguish clinically. It is basically even a PCR diagnosis. Not so. That's it. Anything else? Any other questions? I guess no. So that's it. We can wind up.
In the comment box, I think there is no other questions. Once again, thank you very much, sir, for taking the last questions. I have missed it out for taking it out and then clarifying this. Thank you very much, sir. Thank you.
Thank you. Thank you.
Thank you.
Thank you and good night.